baby to breast, then massaging the uterine fundus, massaging the fundus. Finally get to get some traction.
Bless you.
When in doubt, massage the fundus. I think it's funny. You don't think it's funny, but I do. So, why? Why do we put baby to breast? Why do we massage it? And what condition do we do this?
For body heat?
No.
Post-labor, right? I mean, like, getting rid of, like, placenta, right? Trying to, any
So that
excess
it
blood.
closes.
So just take, you don't have to, you guys are maybe combining them, that's why you don't remember, but why would you just massage the fundus?
So they don't bleed out.
Stimulates the blood to come out.
Stimulates
I forgot what it
blood vessels
stimulates.
to constrict. Why baby to breast?
Isn't to keep the baby calm?
The baby
Like
warm.
like skin to skin or something?
So give a shit about the baby being calm.
Oxytocin.
That's it. That's the reason why. So it stimulates the release of oxytocin, which constricts the blood vessels as well. So this is for the mom who's bleeding, postpartum hemorrhage. That's why you do massage. You don't massage the fundus in somebody not bleeding. Postpartum, baby's out, they're bleeding. You want, nature is not clamping those vessels down, so the two ways that you can help nature is baby to breast, stimulates oxytocin, massage the fundus. That's what I want you to remember. Okay. Releases oxytocin and aids in vascular constriction in the uterus. You guys practice that, the massage?
It's like a scoop.
Yeah, like this, like you're kneading your dough, making a pizza. Yaya's gonna be here around 11 something, and Mark, my boy Mark will be here 10:30 or something. First goes. Okay. Supine hypotensive syndrome, what is it? Why do we care? Who gets it? What do we do about it? Nope.
Oh, is the mom laying down and you would wanna
So the
put it to the side?
pregnant mom is lying supine, and she's hypotensive
Because of the linear vein cable.
Yeah.
because of the
The
weight of the
baby.
baby, weight of the fundus, that we just kind of call like the whole baby and water and all that. Pushes down and occludes the vena cava.
Left lateral.
There might be some aorta too, but the vena cava is the one that we care about, what we talk about more, because it's, which one collapses easier, aorta or vena cava?
Vena cava.
Because it's thinner walls. Okay, so what do you do about it?
Left lateral.
Put on our left side.
Okay, or sit up, or, and then what about CPR? How would you manage, you guys talk about this in your, so you have, your very pregnant patient is in arrest for whatever reason, trauma or postpartum hemorrhage or amniotic fluid embolism, sudden cardiac arrest. So you know CPR is CPR. It's always your basic life support, resuscitative efforts are always gonna be the same. But you have to get that baby off the vena cava. So we tried strapping to a board, putting the board up on the rail, but you really didn't ever get good compressions at 40 to 30-degree angles. So the recommendation now is to take the baby, like it's still inside the mom, right, and just kind of pull towards you. If the patient's on the gurney and you're on the left side of the patient, just try to move that baby off the vena cava toward yourself while you're doing compressions. I can tell you that there's, in the live patient, there might be a 40-point difference in blood pressure with them supine. You're saying, oh shit, 70 over 50, roll them on their side, 130 over 80. Okay, so the initial steps in neonatal resuscitation. There's 3 questions that you'd want to ask yourself or your partner when the baby comes out. What are the 3 questions?
Parents, grimace.
No. That's at 1 in 5 minutes though, right? There's 3 things that you should ask. This is not on the test, this is for your life, your newborn's life. There's 3 questions. Term, is the baby full term or preemie? Term, tone, and crying. Those are the 3 questions. So, are they full term or are they premature? What's their tone in their body? Do they have like flexion in the arms and legs, or are they just floppy? And then, is the kid crying, breathing? That's what we want, or are they silent, kind of gasping? Term, tone, cry. Cry, ventilate, kind of same. Those are the, so when that kid comes out, so say the kid is full term, got good tone, and is actively crying, that kid can go to mom. That's a normal kid, that's baby, skin to skin right away. But if there's a problem in just one of those 3 things, you need to go to work on that kid a little bit. Okay, does that make sense so far? One problem, kid's a month preemie, doesn't go skin to skin, you look at the kid first, because they have a higher likelihood of being ill. Okay, so the initial steps are, you remember, top level up there?
Suction.
Suction would be only as needed. Say again. So position. Well, let me back up.
Stimulation.
Let's see, like warming and drying and stimulating all happen at the same time. So what's that cheesy stuff on the baby? What's it called? It's not on the test. It's more of a.
It's like whitish.
Yeah. It's waterproofing, right? Kids underwater for 9 months. Starts with a V. Vernix. Nobody uses that word. I actually changed my middle name too, so I think it's pretty kind of a cheesy name. Vernix. So you're wiping that off. You are creating friction, which is heating the baby up, and you're also pissing the baby off. That's really what you're doing. And you're pissing the kid off because you want the kid to belt out Shotin. You want that kid to cry, because the kid's crying, they're usually breathing pretty good. It's the silent kid that you should be very aware of. Be aware of. Okay, so warm, dry, stimulate, position, and then suction as needed. So we don't we used to suction, not like that, it's like this, yeah. Yeah, we used to suction crap out of these kids, 100%. We suction, as soon as their head came out, now it's like, really, I've read the studies on it, it's like, for the amount of, they took like 2,000 babies born, like suction half of them, we didn't suction half. The ones that we suction actually did, it's baby's first bowel movement, whatever that name is. It's my second middle name. Like third.
Conium?
Yes.
Okay, so warm, dry, stimulate, position, suction as needed. Suction as needed. How long do you do that for? That's important.
5 seconds.
30 seconds. Because like 5 seconds,
Oh.
you're just trying not to drop the kid, because it's all, look at all that vernix on it.
I think you might have thought about
Suction.
the suction catheter.
You're
tip.
talking about like the yank out
Yeah.
suction, for that first layer of neonatal resuscitation. Okay, so after 30 seconds, what do we do? What are we looking at? Change in what? You haven't, heart rate. Heart rate.
It has to be over 100, right? Or else it'll go medium.
So 100 is the minimum, happy. So if you do this, this and the kid has a heart rate of 120, skin to skin, you're done. You're out of this whole algorithm. Okay, that's what we want is that. And then after a minute, do your Apgar. 5 minutes, do another one. Okay, so you check the heart rate and it's 70 after 30 seconds of what you just did. Top step. Now what do we do? ABM. What size bag valve mask? There's an infant bag. If your company has an infant bag, you'd want to know where it's at because it has a little small. Everything's smaller. I don't have my bag with me, but I have an extra one in my bag. It's like the whole bag is like the biggest part of it's like that. Just it's nothing. And it's got a tiny mask, and so how? I'm just going to tell you this because I know that Mason didn't cover it. You don't hook it up to oxygen. You do on these kids. Just go room air 21% to begin with. Okay, and then a baby neonate normal respiratory rate is 40 to 60. We want you to ventilate 40 to 60 times a minute. If you can imagine that, it's like it's fast, and they're just puffs, just to get chest rise. It's literally just little puffs, puffs out of your mouth, puffs, puffs. You're squeezing your pincers. So, 1 a second or a little bit less than, a second and a half, you can get 40 to 60. And how long do we do that for? 30 seconds.
30 seconds.
Everything is in 30-second increments. So knowing where your shit is and how to get it together and planning for like a neonatal resuscitation is really a big part of this. How would you know that somebody possibly is going to require neonatal resuscitation? Prior to the baby being born. Say again. You have somebody who's on drugs. Be young. Possibly. Yep. Age of the patient. Really old, really young. Possibly. No or poor prenatal care. Lifestyle. A little sketchy. Diabetic. Yeah. I think you mentioned PID. Like a bunch of PIDs earlier on in life. Maybe that sets you up for a bad pregnancy or a bad delivery. Ectopic pregnancies. I think that's a test question, by the way. PID and ectopics go together. Complication. Yeah. So all of those things in the gestational age of the babies in preemie, yeah. So all that stuff, and then I guess we can kind of move into that a little bit. Say if you already know on the way there that the kid's 7 months gestation. So you know that this might be a resuscitative effort, and there's only like I think 1 out of 10 that we do this to. It's not that often. Maybe 1 out of 100. But what are you going to do in the ambulance to set it up, or even in the house? Temperature. So you want to be cooking. If you're inside the house, the recommendation is 70. I'll just make it easy. Just remember 75 degrees on the thermostat. I think it says like 73 to 77. Just get it warm in there. The back of the ambulance, turn your heaters on even in summer. Put them on before you go in. Have that ambulance cooking. And then for the kid, when the kid comes out, you always want to put the beanie on straight away. Get the beanie on the kid. That's where they lose most of their heat. Okay, so 30 seconds, BVM, 1 every second. You're getting good air exchange. And you listen to the heart rate again. Heart rate is 80. Where do you listen to the heart rate? You find a pulse. You find a pulse. Pulse. It's over the mid-sternum with your stethoscope. It's called you listen for it. You don't count, you don't feel it. It's called the apical heartbeat. Apical heartbeat, yeah. Yeah, one person's job is actually, that's your job. I'm not kidding. That is your sole job, is to listen to this kid's chest and be counting his heart rate. Because if it goes less than 60, you don't know it, you need to do something else. Okay, so the heart rate stays 80, go to the hospital. Fast to the hospital. Keep doing what you're doing. If the kid's cold, warm the kid. So that first layer of goodies that you're doing, that, you know, position, warm, dry, suction, stimulate, keep doing that while doing BDM. Maybe even hook it up to some oxygen at this point, because the room air is not helping. You don't have to go 15 liters full tilt boogie, but you know, hit 5 liters per minute, just get a supplemental oxygen. Make sure that you've got good airway management, you're getting good rise and fall in the chest. Yeah. Okay, and you drive. That's it. That's all you do. And you guys know how to do that. You know how to drive, you know how to position an airway, you know how to ventilate. We do it every day-ish. Okay, so level 1, all that stuff. Level 2, positive pressure ventilation. Level 3, now the heart rate is below 60. Now what do we do?
Oh.
Okay, so we do CPR at this point. Okay, so CPR is best practice, thumbs encircling the chest. And the ratio, how many compressions to ventilation?
3 to 1. 3 to 1.
3 to 1. You do it at the same rate as like the adult. Just, you know, 1, 2, 3, breathe, 1, 2, 3, breathe. It's really easy. You guys, I fatigue. I can't do this, by the way, because I don't know how to text. I still text like I'm a retard. But you guys have like biceps in your thumbs. I can't do it. I put these 2 fingers on the chest and just go. That's my move. And either way is fine. There's effective compressions, and still you stop for the ventilation. 1, 2, 3, breath. 1, 2, 3, breath. Okay. And you go to the hospital. Check your sugar. You want to check your sugar? And where do you check your sugar at on the kid? On the heel. Like here's the toes, here's the heel, right there, boom, right on the bottom of the heel.
Yeah.
Anything less than 50 is a problem. It's not the same parameters as an adult. Under 50, that's a deal. 50, 60, sugar. There's something else that we want you to do now, because we have access to it, is to get a pulse ox on the kid. Pulse ox is cool because, especially if you don't have a heart monitor, but you have a pulse ox, you can see the pulse ox gives you the heart rate, the digital reading of the heart rate. So maybe if you believed in it, then it matched up to your apical, and then you could get off the chest while you're doing compressions and see what the underlying heart rate is. So do you know that, so you guys know on the adult we have those clampy things? You'd think if you get something better than that by now, right? You know the Band-Aid ones too. That's what you do on a kid. On their right hand, on the baby's right hand, it goes right around here, like that, the Band-Aid one. I don't know why it's the right hand. I'm sorry, I should know that, because it's a fun fact. But that's where it goes, for pulse ox on a baby. After you dried it off, right, with all the fun stuff. What's that stuff called again?
Burning.
That's it. Okay, that's it. Say, how long do we do those compressions for before we recheck? 30 seconds. And so now the heart rate is 110, and the kid's starting to breathe on its own a little bit. Now what do you do?
Skin to skin.
So you feel safe about it, when you're ready, go to put the baby in the mom. Rarely do you have to do compressions. I don't know anybody that's done compressions on a baby in a resuscitation. The breathing almost always works. I want you to have some confidence in that positive pressure ventilation for seconds to minutes usually stimulates the kid, reminds them to take their breath, gets the heart going. Yeah. Okay. I mean, they've not taken a breath ever. You imagine, like, never have they taken a breath. You're seeing the first breaths of that kid's life. So maybe it just needs a little kickstart. Usually that's what it is. Okay, so skin to skin, you do your 5-minute APGAR. Baby looks we'll get into the aptar in a minute, but you have blue extremities, but everything else looks pretty good. Blue extremities, I would consider blow by oxygen. And that blow by oxygen could just be that, like if you pull so you hook it into the oxygen bottle and turn it on, and just, you pull the other side out of the non-rebreather, just have the hose there. Just give them a little bit of supplemental oxygen. That would be okay.